Well, welcome everyone. We're super excited to host once again a heart health webinar partnering with UW Heart Institute. As you know, February is American Heart Month. Our goals really are to raise awareness about heart health and urge everyone to take steps to prevent heart disease and become aware of your own heart health. Today, we're going to be hearing from cardiologists Dr. Kevin O'Brien and Dr. Ruchi Kapoor. They are going to address warning signs of heart disease, how we can protect our hearts. And we were just speaking actually about how just recently the new data came out. So this is a perfect time of year to be talking about updates to heart health. Dr. Kevin O'Brien is an attending physician at UW-MC and a UW professor of medicine. He's an expert on congestive heart failure, cardiac transplantation, and lipid disorders. He's been practicing in the field for over 20 years. Dr. Ruchi Kapoor is a board certified in internal medicine, did her cardiology fellowship at UC Irvine, provides comprehensive general cardiac care with a focus on women's heart health and prevention of heart disease. So lots of knowledge here with us today. Just a few room etiquette. We're going to save questions for the end, but feel free to send them in the chat throughout. You'll have time to raise your hand if you have questions. And we are recording, so we'll be putting this on YouTube. We will cut out the questions at the end for YouTube, and just in case anyone doesn't feel comfortable with their voice or their own personal question being out there. All right, with that, I'm going to go ahead and pass it off and just thank you both so much for being here.
Great. Thanks, Anna. Can you hear me okay?
Yes.
Okay, great. So here are my objectives for today. The first is to understand why heart attack and stroke are equal opportunity diseases. Secondly, to describe the symptoms of heart attack and stroke, because recognizing that you or a loved one might be having a heart attack or stroke quickly is really important. And then finally, analyze why prompt recognition and treatment can save lives. So this is an old picture from a physician named Frank Netter, who did these fantastic medical illustrations showing the typical heart attack patient is a gentleman. He's exerting himself, it's cold, and he's having the symptoms of central chest pain, clutching his chest. But I'll go through in a minute why the symptoms those typical symptoms are not necessarily seen in everyone, and talk about other symptoms of the chest pain syndrome that could signal that you might be having a heart attack. So this slide shows the top 5 causes of death in the United States in women. Number 1 is heart disease, and number 4 is stroke. And so again, I think that's a great reason to talk about this with everybody. And in men, the top heart disease and stroke are also in the top 5, though number 3 in 2015 was accidents. So that's apparently we don't exercise as a good judgment in all situations. But overall, 30% of deaths in both women and men are due to heart attack or stroke. We talked about, so we wanted to go through the potential symptoms that you might be having a heart attack. The first is chest discomfort that classically occurs in the center of the chest, lasts more than a few minutes. And we talk about chest pain, but in most people, the symptom is more like pressure, squeezing, or fullness. Well, some people also have pain, but these other symptoms in the center of the chest could be signs of a heart attack. But you could also have discomfort in other areas of the upper body, including the arm, especially the left arm, the inner side of the left arm, the back, the neck, the jaw, or the stomach. And so particularly if you think about it, it's sometimes very, very difficult depending on how an individual's heart pain is manifest to distinguish that heart pain from gastrointestinal pains. And that's due to the fact that the heart and the internal organs aren't innervated as robustly as the skin, for example. So it's harder to localize the exact spot from which the pain is arising for these internal organs. You can also have shortness of breath that could occur with or without chest discomfort. The shortness of breath at rest can also be a symptom of heart attack, as well as other problems. And then the other signs that can occur are cold sweat, nausea, or lightheadedness. So those are the symptoms that can occur if you are potentially having a heart attack. So now, what about a stroke? So the American Heart Association and the American Stroke Association have come up with this mnemonic. It originally was FAST, but now they've expanded it to be fast. And so I'll go through what each of these letters stands for. So the first is balance. B is balance. So is the person suddenly having trouble with balance or coordination? That can be a sign of stroke. Eyes, is the person experiencing suddenly blurred or double vision, or a sudden loss of vision in one or both of the eyes without pain? That also could be a sign of stroke. The third potential sign is F for face drooping. Does one side of the face droop, or is it numb? Ask the person to smile, and if they're not able to raise both sides of their face equally, that it can be a symptom of stroke. Arm weakness. Is one arm weak or numb? Ask the person to raise both arms. Does one drift downward? That would be a subtle sign of arm weakness and potentially a sign of stroke. Speech. Is the speech slurred? Is the person unable to speak, or are they hard to understand? One of the ways you can, if you suspect this, one of the ways you can kind of confirm it is to ask the person to repeat a simple sentence, like Sally sells seashells by the seashore, which isn't really that simple. But that can bring out or confirm that their speech is slurred. And finally is time. And so if a person has one of these 5 symptoms, then it's time to call 911. Even if the symptoms go away, because they need to get to the hospital immediately, so that we could potentially give treatments that could decrease treat the stroke early, decrease the amount of damage to the brain, and improve the patient's odds of recovery or even survival. And so in both heart attack and stroke, this early recognition is very important because the longer the heart or the brain are deprived of blood and oxygen, the more damage there is to the tissue. So here's an example of that shows on the y-axis the percent of heart muscle cells surviving as a function of the time from onset of symptoms. So you can see that there's a really rapid early loss in the percent of survivable heart muscle cells after the heart artery becomes blocked and the blood supply to a part of the heart becomes blocked. So that by 3 hours, you've lost more than 50% of the heart muscle cells, and by 6, it's over 90%. For the brain, the rate of loss of brain cells is even more rapid, so that you really even need to act more quickly, if anything, in patients who have potential symptoms of a stroke, to apply these therapies that we could use to open the heart artery or the brain artery early to minimize the damage to the heart or brain tissue. So in the case of a heart attack, what we'll typically do now is put in a catheter that has a stent, a kind of a cage that's mounted on a balloon, cross the area of blockage with this apparatus, and then blow up the balloon to expand the stent, so that when we deflate the balloon, that stent props the artery open and maintains blood flow to to the heart. In the case of strokes, the approach, more typical approach, is to actually give an infusion of a clot busting medication called TPA, tissue plasminogen activator. And what that does is, when it's injected intravenously, the medication goes to the site of the clot and works to help break the clot down to restore blood flow. So two different ways of restoring blood flow for the heart and the brain in response to a blocked artery, but both very effective if we can apply these therapies early. So to summarize this part of the talk, we want to know that heart disease and stroke are the cause of death in 3 out of 10 Americans, to recognize the symptoms of a heart attack, which can include discomfort in the chest or arms, neck, jaw, or abdomen. And can be discomfort, not necessarily pain. And for stroke, to remember this mnemonic, BEFAST. So balance, eye problems, facial droop, arm weakness, slurred speech, and then the T is to call 911, because time is of the essence. And then finally, as I said, call 911 to get help as soon as possible. Now, I did want to talk briefly, though, about a new cause of heart disease death. And so in 2020, COVID-19 moved up to number 3 in the United States as a cause of death in both men and women. And this slide is kind of complicated, but I'll walk you through it very quickly. So this shows each bar is the number of deaths per week from January 1st of 2018 through January 1st of this year. And you can see that there is look at the red line here, that shows the average of deaths over each week. So you can see that there actually are more deaths in the winter every year due to primarily to respiratory illnesses, but also heart attack and strokes are more common. And then what you see here in 2020 is how the number of weekly deaths markedly increased from the usual baseline throughout the year, corresponding to these different waves of COVID infection up through into January of 2021. And then in the late summer of 2021, we had the Delta wave and then the Omicron wave that were associated with excess deaths. And then finally, we've continued to have excess deaths over expected throughout 2022. But the number of excess deaths are down, unfortunately, primarily due to vaccines. But here's the surprising thing. This is a little bit complicated slide as well, so apologies for that. But basically, what it's showing is the number of deaths per week from various causes, respiratory diseases other than COVID, and as well as heart and circulatory diseases. And the red line, so the gray lines are the previous 5 years before the pandemic, the number of deaths per week. And then the red line are the number of deaths in 2020. Orange line is 2021, and the light purple line is 2022. So not surprisingly, there are a large number of respiratory deaths in 2020 during the early stages of the COVID pandemic. But people with heart disease really were at increased risk of dying as well. So in fact, the excess deaths from circulatory diseases exceeded the number of deaths from respiratory diseases during that period. In the subsequent 2 years, since we were wearing masks and isolating, actually the number of deaths from respiratory illnesses above expected were lower in 2021 and 2022. But unfortunately, the number of deaths from circulatory diseases has continued to be higher in the subsequent 2 years than it was before the COVID pandemic. And we think a lot of this is due to continued heart deaths from heart disease in patients who had COVID, but also delayed care in people who were unable to access the medical system during and get care for their heart conditions during COVID. So the solution to that are vaccines. This shows a relative likelihood of having myocarditis or inflammation of the heart from the vaccine, which is rarely fatal, versus the risk of dying or the risk of being hospitalized with COVID-19 for people in different age groups. And you can see how the benefit to risk ratio really is dramatically in favor of COVID vaccination, especially in older age groups. And even in younger age groups, the benefit far outweighs the risk of COVID. And then this slide shows the numbers of deaths per day throughout the pandemic until estimated through till April of this year, and number of beds utilized, number of patients hospitalized with COVID in the state of Washington over that 3-year period as well. So you can see the number of deaths peaking with each of the successive waves. This was the Omicron wave, and corresponding increases in the number of people hospitalized. But something's happened now here in the last year, and that's related to us reaching a fairly high level of vaccination in Washington State. The darker green are the proportion of people over time who got at least one shot, and the lighter one, it shows the number of people that have gotten at least 2 COVID shots. So just as predicted from that previous slide, what we're seeing is that we're getting, as more people are getting vaccinated, we are starting to get a handle on the numbers of hospitalizations and deaths from COVID. So in summary, heart attack and stroke cause 3 out of 10 deaths in both women and men. The symptoms can be a little bit different in women as compared to men, and Ruchi's going to go through that in more detail in her talk. But just to emphasize that it's not necessarily just chest pain. You can have discomfort, pressure, squeezing, pain, and you can have other symptoms like shortness of breath or sweatiness. And the pain could occur in the chest, but it could also occur in the left arm, the jaw, the neck, or the upper abdomen. For stroke, remember this mnemonic, be fast, so balance, eye problems, facial droop, arm weakness, and slurred speech, and make sure you call very soon. Call 911 if you develop any of these symptoms. And the reason we need to be quick about it is because the sooner you get to one of these life-saving therapies for heart attack or stroke, the better the outcomes for patients. And then finally, vaccines are good for you, so make sure you get boosted. Thank you.
All right. Thank you so much, Dr. O'Brien, for that very helpful talk. I tried to keep up with a couple of questions at the beginning, but then I realized that maybe it would be better if we did answer a lot of these questions at the very end, because I think hopefully I'll help answer some of these questions in my talk. So, I think Dr. O'Brien laid a very nice groundwork to kind of talk about the introduction to my subject, which is essentially talking about ischemic heart disease differences in men and women, but I wanted to talk about what is ischemic heart disease, or sometimes we just call it heart disease. And this is a picture of somebody's, if we fill all the blood vessels that supply blood to the heart muscle with red waxy substance, and then we take all the actual muscle away and all the tissue away. This is our vascular tree. These are all the blood vessels that the aorta, the kind of the big pipe that takes blood from the heart to the brain and all the other organs of the body. But the branches, the openings to the coronary arteries are right as it exits the heart. So heart gets first dibs on all that wonderful oxygenated blood. And when we have ischemic heart disease, what that means is that there's essentially blockages in some of these blood vessels right here. And how we look at it in somebody who we suspect is having major blockages is we do a coronary angiogram. So this is, we have a catheter that goes kind of backwards through the aorta up right here to the openings. And we inject contrast dye into the blood vessels, and we see how the contrast flows down the major branches and then some of the smaller branches also. We tend to see sometimes diffuse atherosclerosis or plaque buildup, which is often more often seen in younger women who have ischemic heart disease. And that's just you can see if the true opening size of the artery is here, and then it's just kind of lumpy, bumpy along the way and just kind of gradual narrowings. However, if we have a localized stenosis or kind of very spot of major blockage, that kind of obstructive heart disease, we do tend to see that mostly in men and in older women. But we do tend to see both kinds of our atherosclerosis in both men and women. It's just we tend to see this form a little bit more often in women. What the symptoms tend to depend on how quickly that blockage develops. But the first test is really looking at somebody who's having some who are having chest pain, tightness, and we'll go over that a little bit more. But when we look, we generally see that initially there is no blockage, but gradually there's some plaque buildup. But that plaque buildup can also lead to the small, tiny branch arteries can have poor blood flow in those tiny branches, and we call that microvascular disease, where this is all technical language from a very technical article, but to kind of explain that there is poor blood flow related to the tiny branch arteries in addition to the bigger branch arteries. And of course, we also have the other kind of heart disease, which can lead to spasms, just like you have muscle spasms, kind of Charlie horses, you can get some equivalent spasms in the small branch arteries, which can also lead to narrowing. So we have few different kinds of heart disease, some that are related to plaque buildup, but some that are also related to poor flow because of how the small branch arteries are dilating or not dilating, enlarging and not enlarging. But a lot of these can also lead to symptoms related to ischemic heart disease, related to poor blood flow to the heart muscle. And in some cases can also lead to death. I did want to take a very brief aside and talk about differences between a heart attack and a cardiac arrest, because this has been in the news a lot. Heart attack is when we kind of get that atherosclerosis, that plaque built up in the arteries that supply blood to the heart muscle. And we get this major blockage, and it's really a circulation problem related to symptoms that the chest heaviness, getting sweaty, can't breathe, sometimes nausea. All of those symptoms that you kind of typically see are really related to a heart attack or ischemic heart disease related to poor blood flow. A cardiac arrest, what we saw on TV with Mr. Hamlin, is really an electrical problem where there is a major, sort of the best way I tend to think of it is an electrical storm that really means that the heart muscle stops working. So here, when you have a heart attack, you don't get blood flow to the heart muscle, but when the entire heart is having a cardiac arrest, you don't get blood supply to the entire body, including the brain. So when we talk about timeline, how important is time? For a cardiac arrest, the time frame important is on the order of minutes. You can only go a couple of minutes without blood flow to your entire body. Whereas for a heart attack, it was, if you remember Dr. O'Brien's graph, it really is, we're talking on the order of hours. So 2 to 3 hours, but ideally, of course, we want to get things moving within the first few minutes in both of these situations. So if you see somebody having a cardiac arrest, meaning they are essentially dropping in front of you and don't have a pulse, first thing, call 911. Second thing is you take the place of the heart. You do the pumping that the heart cannot do in those very few moments, and you do CPR. And now these days, CPR is you just do deep and fast and hands-only CPR. We don't really encourage people to stop and give the breaths that we used to back in the day. Now it's really hands-only CPR. And most cardiac arrests, just so you know, 70% of them happen at home. So having as many people as we can out there trained in doing CPR is really the number one way we can save these people. Certainly, if we have an automatic defibrillator handy, getting that out, getting the pads put on, delivering a shock if you can. But the number one thing that you can do for somebody who's having a cardiac arrest is calling 911 and then providing those chest compressions, which keep blood flow going to the brain and to the body. With a heart attack, somebody's generally speaking still awake, but having symptoms related to that blocked artery. And so you still call 911 or go to the emergency room. But that's not a person who, they still have a functioning heart, but much weakened. So you don't necessarily need to do CPR on that person, but if you have aspirin handy, give that to them. A lot of times people can't be sure if their symptoms really are related to a heart attack or not. That's okay. Even if you don't know, still definitely go to the emergency room or call 911 because we can do an EKG, we can do a blood test to really check for that. Why do we care about this? It's because cardiovascular disease is the #1 killer in the United States. I think Dr. O'Brien kind of showed a lot of the data already on this. This is from the 2022 update of heart disease and stroke statistics. But what we see is that in whites, Blacks, Asians, Hispanics, in all ethnic groups across the United States, #1 killer is still cardiovascular disease, followed by cancer in most of the other groups. And I do want to highlight that, for Blacks, this is kind of highlights the inequities in our society, I think, is the number, in the top 6 causes here, we get assault and homicide for Blacks, but it doesn't show up for the other ethnic groups. But regardless, cardiovascular disease more than cancer, and that's true for both men and women. And that's always surprising a little bit to people that heart disease kills more women than, say, breast cancer. Looking at trends from cardiovascular related deaths over time. In red, we have men, and for a while we worked really hard and we started seeing a downtrend in deaths from cardiovascular disease starting in 2000, 2010, and then up to 2019. There was this gradual uptrend. And same thing for women, we were gradually decreasing, I'm actually reversing these. For men, we saw a gradual downturn, and then we saw an increase in the number of deaths related to cardiovascular disease starting in 2010. For women, it took us a lot longer to kind of achieve that same downtrend, but then it also started increasing. And for a while there, between 1990 and 2010, we see that women had more death related to cardiovascular disease than men did. Again, another surprising fact for a lot of people. We finally managed to reverse that in the 2010s. And of course, this data only goes up to 2019, and I didn't get a chance to update my slides. but we did just get they just released the statistics, which include the first year of the pandemic. And I'll tell you that it's quite surprising that there's or maybe not so surprising based on what Dr. O'Brien showed us, but there was a dramatic uptick in death related to cardiovascular disease in the first year of the pandemic. A lot of times, we talk about why was that difference, why this difference existed between men and women. A lot of that was related to women not calling 911 because they don't think they're having a heart attack. Heart disease tends to be thought of just as a man's disease. These are, statistics or quotes that after interviews with women about what their thoughts are on heart disease in women. A lot of them feel like they're too stressed or too busy to make changes in their lives. They're too tired. They don't think they're old enough to be at risk. That's a big one that I find in my clinic myself. And so this was a very interesting 2012 study that showed that 81% of women would call 911 if they thought somebody else was experiencing symptoms that they thought were maybe heart attack symptoms. But only 65% would call if they thought they themselves were having a heart attack. And to me, this discrepancy is huge. Why would they not take their own symptoms seriously? Partly because I think women are so used to being the care providers for other people that they really neglect their own symptoms. And again, going back to the previous slide, this kind of highlights why that 24% difference exists here. And then, of course, the main thing that should be highlighted is that symptoms of heart attack are a lot more varied in women than in men. Number one symptoms is still chest discomfort. It doesn't always have to be pain, but it's still squeezing, tightness, just can't tell really what it is, but it just doesn't feel good in the chest area. But it may not be the chest area, it may be in the jaw, in the back or neck area. But women tend to get a lot of other symptoms along with the chest discomfort. They get nausea, shortness of breath, feeling just faint and fatigued and thinking that it's, more like acid reflux or indigestion. I have this wonderful patient who had a heart attack, got a stent, 2 years later had similar symptoms, but for some reason, despite her prior experience, she thought it was indigestion and didn't go to the hospital for a day or two until the symptoms didn't go away. And she thought maybe it was related to her heart instead. So the other thing that I wanted to highlight for who gets heart disease, the differences between men and women, is that women tend to have later onset of heart disease, cardiovascular disease in general. Turns out that menopause is or estrogen is a bit of a protector, and then we kind of lose the protective effects is that when we start developing heart disease in our 60s and 70s, as opposed to men who tend to get them at a younger age in their 50s and 60s. And I already showed that for a while there, women did have higher risk of dying from cardiovascular disease, but that's changed. And women tend to have we talk about risk factors for having heart disease, and women tend to be at higher likelihood of having high blood pressure above age 65. They tend to have, when they do have high blood pressure, their blood pressure control tends to be worse. They're at increased risk of diabetes, obesity, and psychosocial stressors compared to men. So they have all of these risk factors that they tend to develop. And a lot of these tend to be ignored more or worse controlled in women. I tend to think about, what are these risk factors that we have control over and the risk factors that we don't have control over. I think Yeah, sorry. So some of these modifiable risk factors, certainly smoking, now vaping, nicotine, which is unfortunately making a bit of a comeback. That's a big modifiable risk factor, getting control over blood pressure, glucose, cholesterol, and how much physical activity you engage in, obesity, alcohol consumption, and certainly psychosocial stressors to a certain extent are modifiable risk factors, not all the way. But things that we definitely can't control, aging, unless somebody's come up with an elixir of life that I don't know about, family history, the genetics that you're born with. We don't understand all of them, but we do understand a lot of them, and trying to come up with ways that we think are some of the risk factors are modifiable, coming up with certain specific treatments for them. Maybe in the future, but right now we don't know everything about the genetics that cause heart disease. Pregnancy, again, this is, we talk about as a risk factor for somebody, certainly certain women who have during pregnancy, they have gestational hypertension or gestational diabetes. Those are risk factors that really come about during pregnancy and is a prediction of somebody who's at higher risk down the road. Autoimmune diseases like rheumatoid arthritis, and certainly breast cancer and certain treatments for breast cancer like radiation and certain chemotherapies can increase cardiovascular risk in the future. But ultimately, there's more items in the modifiable category than in the non-modifiable category, and which emphasizes that about 80% of cardiovascular disease in women is preventable. We have the tools for it. And certainly, I already mentioned some of these diabetes, gestational hypertension, preeclampsia, oral contraceptives, being aware that some of them can increase the risk of cardiovascular issues, and radiation specifically for breast cancer. I want to kind of take home point from and if you just ignored the rest of my talk, the things that I want you to take home again are the symptoms to watch for. It's not always chest pain for women, it's chest discomfort, can be shortness of breath, sweating, fatigue, being dizzy, nausea, and body ache, sometimes something very non-specific like that. And things that you can do to stop, to help your heart and reduce your overall risk. Remember that 80% statistic I told you. Number one is stop smoking, and I really need to update this to say vaping. Exercise. Our goal should be about 150 minutes of moderate intensity exercise a week, and alternating that with strength training. Having a heart healthy diet, and really thinking about food as nutrition, and how as fuel for the body, and how are you fueling your body. So talking about a diet that's really rich in fruits and vegetables, whole grains, fibers, and really minimizing processed foods that are high in saturated fats. Trans fat, we really don't have to worry so much about anymore in this country because it's pretty much banned. But really paying attention to those nutrition labels on your foods and looking at the sodium content and the added sugar content in particular. Blood pressure, really our goal for blood pressure should be 120 under 80, the bottom number, the diastolic number. And some of the things that we can do lifestyle wise to help control blood pressure and keep it under control is watching your weight, following a low sodium or no sodium diet if you can, and really being physically active, moving more in your day-to-day. Optimum weight, of course, we talk about BMI, which is an imperfect metric of size, but having a BMI generally under 25 is better for your overall health, and waist size is predictive of of cardiovascular disease, and having waist size under 35 inches is optimum. But ultimately, what I would encourage most people to do is just know your numbers, know your blood pressure, your fasting glucose or A1C, which is a metric of diabetes, know your cholesterol numbers, know your kidney function, and be aware really of what you're putting in your body and how much you're moving around in your day-to-day life, because all of these things really make heart disease preventable. And I just wanted to thank you all for your attention and open to questions.
Thank you both so much. Just so much great information. I'm going to go ahead and start by going down the chat. We've got a ton of questions pop in. My chat is actually buffering pretty slow, so if I get paused, I might have to ask you to help me, Ruchi. But the first question that we haven't answered yet is, how do you know when you're coming up with a treatment plan if a vessel is strong enough for a balloon?
That one, so a lot of times the balloons, this is a very technical question for interventional cardiologists, the ones who go in and put stents in blood vessels. Most of the time, our blood vessels are strong enough. The balloons that we use are made for those blood vessels, and we keep very careful track of how much balloon pressure there is in the blood vessel. Sometimes the blood vessels are very calcified, particularly in older people. And that makes it really hard to kind of just blow up a balloon in there. And so sometimes we have to prepare those sites. But generally speaking, it's a very specific set of tools that we have for that.
Great. Some of this you just spoke to, but maybe just as a quick refresher, what are kind of the tests or the conversation you should have with your doctor just to see if you're at risk for heart disease, attack, or stroke?
So to kind of reemphasize, that's the know your number slide. So having your cholesterol checked at least once every 5 years, know your blood pressure, and you don't even have to go to your doctor's office to get your blood pressure checked. You can go to a pharmacy, you can go to your local fire station, you can get a blood pressure cuff at home and do it. But knowing kind of where your blood pressure ranges, and very important, when you do check your blood pressure at home, make sure, your feet are flat on the ground, your back is supported, but at the same time, make sure that you've been kind of just chilling out for 5 minutes. So no phone, no TV, no talking, and that just kind of gets your blood pressure to a steady state level, or the lowest, most relaxed number. And that's the one that we really want to track. So measuring your blood pressure at home is a great tool, but doing it correctly and keeping a log that you can take to your doctor's office and to your doctor, and reviewing those numbers and seeing if there's some changes that need to be made.
Yeah, and I just add to that too. There are online calculators that into which you can, Framingham is a classic one, where you can enter your age, your gender, your cholesterol numbers, your blood pressure, and so forth, and it will let you know what your risk is for heart attack or stroke relative to other people your age and gender. So that's also a good way where if you know your numbers, you can actually get an estimate of how increased your risk is, and it also helps to target which specific things might benefit you in terms of a reduced risk.
Oh, that's great to know. What was the name of that resource one more time?
Framingham.
Thank you.
The other one that is used a lot is the pooled cohort equation. It's an ACC-AHA calculator. I could find links to those and put them in the chat. Okay.
Great. There's a few questions in here about, I'm going to pronounce this wrong, atherosclerosis, talking about, are there other screening tests in additional to cholesterol And then also just any guidelines around exercise.
So screening tests for atherosclerosis, which is actually a mouthful. So we can just summarize it as plaque. Screening tests for plaque buildup in the arteries of the heart. So there's some out there. The one that I tend to use most often in my clinic, and I'd love to kind of hear what Dr. O'Brien has to say about it, is in people who are at sort of low, not low, but medium risk, or people who've been kind of following all the right diet, right exercise, but have really strong family history. For individuals like them, where we want to know whether how aggressive to be with medications, for those individuals, I do a coronary artery calcium score. And it's a CT scan, so there's some radiation associated with it, and not a lot of insurances unfortunately cover it. So it's out of pocket, a couple of $100. But it's really a test to look for calcium buildup around the arteries of the heart. And if somebody has, certainly people in their 40s really should have minimal to no calcium buildup. And somebody like that, it's predictive of increased cardiovascular events and suggests that they already have some amount of plaque buildup in their arteries of the heart. And the score for that calcium score matters. So 0 to 100 is sort of, low moderate risk. But anything above 100, I tend to consider as equivalent really to having heart disease, and tend to be a little bit more aggressive with medical management in those patients. So that's one additional tool that I tend to use in my practice, in addition to the risk scores that Dr. O'Brien just mentioned.
Yeah, these other tests that are available can be helpful, particularly if your risk is at a sort of equivocal level where you and your doctor are trying to decide whether or not you should start on medication, for example, for cholesterol. So those are kind of the situations where I might get a calcium score.
Yeah. The emphasis being on picking the right person to do that test on. It's not a test that I would do really on a 20-year-old, 30-year-old. It's not a test that's the right test for even 70, 80-year-olds, or somebody who's already had a heart attack or is already on a statin. It's for a very specific group of people. So it's not the right test for everybody, but a good screening test in some individuals.
And I think that, it's something you'd want to have a discussion with your doctor about whether or not it might be useful in your particular case. And again, I think that these free and widely accessible online risk calculators are the most well validated for assessing your risk and figuring out how you can improve it.
Yeah.
Thank you. And the question that kind of went along with that is, if you have been diagnosed with heart disease, let's say you have plaque buildup or something of that nature, at what level should you be exercising without kind of inducing symptoms that might seem like you are having a heart attack?
Go ahead, Kevin. I wasn't sure if you were about to speak to that.
Oh, no, that's okay. Go ahead, Ruchi.
Yeah. So that's a really good question. And what we know is that, certainly exercise, in some ways, oddly, can be a trigger for heart attacks. In some people. And so you hear about somebody who starts clutching their chest at the end of a marathon or something like that. That said, the longitudinal benefit of exercise in terms of improving your cardiovascular health is so important that kind of minute increase in risk in that moment of doing exercise is really, it's worth doing the exercise for. So a lot of times, I don't want to exercise because it increases my risk of heart attack. Well, it does, but the long-term benefit is just too important. That said, a lot of times we send people after they've had a heart attack and they've had a stent or bypass surgery or something like that, we actually send them to cardiac rehab, where they gradually build up their exercise ability under supervision to as much as they can tolerate. Your body will tell you, right? The chest symptoms will, if you start getting chest pressure, chest tightness, that kind of is a predictor. Okay, at that level of exercise, now my heart's suffering from lack of blood flow. A lot of times, if it becomes a limiting factor where you can't walk, a block before you get those kind of angina symptoms, it's not a word we've used so far, but it's symptoms related to poor blood flow to the heart. If you start getting those symptoms, for example, after a block, and it's really limiting your life, then, we start talking about medications to help improve blood flow. And again, going back to it and talking about diabetes control, blood pressure control, cholesterol control, we kind of end up being like a little bit like a broken record, just so cardiologists do, because those things are so important. But then we can start adding medications that don't necessarily reduce your risk of heart attack, but they will help with the symptoms. And if at some point we run out of medications to help with symptoms, we do refer people for the angiogram procedure to look for any, or a stress test to kind of look for where poor blood flow is, and an angiogram to see if putting a stent in or opening a blockage up would be helpful to relieve the symptoms. But we have a lot of things that we can do before we get to that step.
So there's a lot of, oh, please.
Oh, go ahead. Well, I was just saying, one of the attendees mentioned, I'm sorry, the tragic story of her husband that had a heart attack and had heart block, or died suddenly and had heart blockages that weren't recognized beforehand, and found to have those heart blockages after they died, and exercised a lot. So this is the other challenge that we have, is that not only can people's symptoms be different, but there's some people that don't have much in the way of symptoms at all, even though they have significant heart disease. So I say it's those are really unfortunate cases. But again, I think the idea of making sure you do what you can to control your own risk is important, by knowing your numbers and talking with your doctor about them.
Yeah, thank you for speaking to that. Kind of along those lines, there's quite a few questions in the chat, giving examples of, let's say I experience neck discomfort or little lightheadedness, but then it subsides, or I just feel pain in my right arm and then not being sure whether to make a call or not. Can you speak at all to kind of the severity of symptoms, or I'm assuming again, it's kind of that it's different in everyone approach?
That's hard. And, it's a great question, because it's such a hard thing to kind of tease apart. What if you get pain in your right arm, is it related to your heart or is it something else? And the one kind of helpful hint to whether it's related to heart disease or not is whether it happens with activity. So, it kind of goes back to, of course, we have some people who don't have symptoms with even a high degree of blockage in the artery. But for most people, if they start getting angina symptoms, it's usually when they're making their heart work hard. So when they're walking or climbing the flight of stairs or going on a hike or anything where they do that activity and the heart's pumping harder, it's pumping faster, it needs more blood flow. And if there's some level of blockage, then whatever the symptoms it is, and the heart's not getting enough blood flow, whatever the symptoms, it comes out usually around that time is with activity. So if it's, you start consistently getting that left shoulder pain, which you thought was just always arthritis, but it tends to happen even when you're not using your arm much, you're just walking across a hall or, going up a flight of stairs, and you tend to get it consistently. Or tend to get, indigestion pretty consistently with activity. Those are hints that it may be more related to the heart than muscle or joint pain or something like that. which is, I want to emphasize, a little bit different from heart attack symptoms. Heart attack is a sudden blockage in the arteries of the heart. And so that can happen while you're sitting, but it tends to be more severe symptoms. So if it's just sort of mild symptoms that tend to happen with activity and exertion, then, the question is it coming from the heart? And we can do stress tests to evaluate for that. But if it's something very sudden that happens while you're sitting down, or even, and sudden can mean over a span of hours, it's usually worth getting checked out at a doctor's office or really an emergency room to get the test done, EKG done, to make sure you're not having an actual heart attack.
Anything to add there, Kevin?
No, I think that's great advice.
Great. Another question, and sorry, folks, we've got so many questions, so I'm trying to jump around, was talking about seeing alcohol on the list of potential contributing factors. Can you talk a little bit about kind of guidance around alcohol consumption? Of course, probably as little as possible, but many people enjoy their beverages, so.
I think you got it. It's as little as possible, in the sense that, we say up to 1 drink a day for women, 2 drinks a day for men. Is anything more than that is too much. But it also doesn't mean that you get to save them up. So if you don't have any drinks during the week, and then on weekends you indulge in 10 drinks, that's again going too many drinks at a time. It's not, you kind of hear the literature and the kind of colloquial news media, having a glass of red wine a day is good for the heart. But we don't recommend that. Why? Because it's a slippery slope, and I think we know that alcohol is a big risk factor for certainly for high blood pressure, for arrhythmias, for heart failure, for other diseases that are not related to the heart. So it's I think alcohol in some ways is a double-edged sword, and one edge tends to be a little bit sharper than the other. So kind of finding that balance between what's too much and having just occasional consumption is hard. So I don't make strong recommendations for it. But certainly I do make some recommendations against it in certain people.
Yes, and those old studies that suggested that maybe a glass of wine a day was good for your heart were based on its ability to raise your good cholesterol level just a little bit. And it's actually raising your good cholesterol level by a number of different ways have turned out to not really translate into health benefit, with the exception of exercise and weight loss. Exercise and weight loss will raise your good cholesterol in a way that is actually associated with better cardiovascular health outcomes.
Yeah.
Just to close this out, there's a lot of questions asking about trying to understand, taking in all this information, what is your personal or your loved one's risks, and then factoring in previous conversations that have been had with doctors and maybe feeling a little unclear. Can you give any advice or recommendations around how to approach conversations around heart health with your doctor, and maybe, how to seek out, additional information, and maybe when to consider seeing someone else, or, things around that guideline?
Yeah. It's, I think, it's a difficult conversation, because it's not, oh, yes, you have it, or no, you don't have it. Very rarely does it work out like that. And a lot of my conversations in clinic are, certainly you have the risk factors, you probably have some level of plaque buildup. We used to be sort of a few years ago, we used to do routine stress tests on people to look for blockages in the arteries of the heart. And turns out that's not really beneficial or helpful to people. it's really a matter of finding the optimum sort of tools for that individual in terms of preventing the future events, and doing routine exercise stress tests and angiograms and coronary CT angiograms and, you know, all these other tests really isn't beneficial in preventing future cardiovascular events. What we find over and over again is it tends to be about controlling your blood pressure, controlling your cholesterol numbers. And just, I want to highlight something very quick here, that cholesterol numbers, what level of bad cholesterol we target, how low we bring it down, really varies from person to person. For some person, you know, we say, oh, LDL of 100 is fine. But for somebody, for example, who's already had a heart attack or stroke, we want to be even more aggressive and bring it down further. So what's a normal cholesterol is actually a little bit of a moving target. So a lot of my conversations in clinic kind of hover around talking about risk factors and knowing that, yes, acknowledging that you probably have some level of plaque buildup already. And the idea that cleaning that plaque out is, you know, going in and roto-rootering is not the answer to long-term cardiovascular health. It's the answer there is really to prevent future progression of heart disease. The answer is stabilizing whatever plaque has built up so it's less likely to break off and cause a major blockage, and really to engage in a lifestyle that's sustainable, because a lot of people go on binge diets or binge exercise programs, and that's not sustainable. So finding something that works for the individual in front of me, but also kind of helps maintain their heart in healthy, good shape in the long term. And it's a comprehensive approach, right? We talk about the major risk factors, but I ask my women in patients, female patients who come to my clinic, whether they had any complications with their pregnancies, whether they have any autoimmune diseases. So for somebody like that, I may choose to do a calcium score or a stress test. So I think having some of those nuances to the individual in front of me is pretty important. And I think a lot of primary care doctors are open to these conversations, but I know I'm always available to kind of do these prevention discussions with patients also.
Yeah. And I did want to briefly address some questions in the chat about when to start statins, what about Lp(a), and also to address a question about you know, about whether to get a second opinion. Yeah. So I get, you know, anytime you have, it's always good to have a conversation with your doctor. If you have questions after that, it's not ever unreasonable to get a second opinion if you're unsatisfied with the answer. There's a question about who should start statins and when, and that's an individualized decision, is based on your risk, based on your own level of risk. Again, having a conversation with your doctor, your level of risk you can determine with one of these online calculators. Lp(a), lipoprotein(a), is a powerful risk factor for cardiovascular disease. And there are some specialized treatments for that now. If you have questions about that, the UW Lipid Clinic is a good place to go. And I just put their number in the chat.
Yeah, thank you so much. Well, just overall, thank you all, and thanks everyone who attended. Of course, I'm sure there's many questions we didn't get to, but I think our biggest takeaway is that there's a lot of tools we have to take our heart health into our hands, and to use those and also have those critical conversations with our loved ones and our doctors. So thank you both for all of your knowledge and information. As I said earlier, this is being recorded. It'll go up on our YouTube, so we'll share that link with you all as well. With that, I hope everyone has a great rest of your day in February, and we look forward to hosting you in the future.
Yeah, thanks very much.
Thank you.